So as people are strolling in, we're gonna get started. And you know, it's a great pleasure to introduce Dr. Ajay Wasan. He is professor and vice chair of pain medicine in the Department of Anesthesiology at University of Pittsburgh Medical Center. It's hard to summarize his background because it's such a illustrious and also very complicated. But after graduating from college and medical school at the University of Illinois at Urbana-Champaign, he got his master's degree in medical anthropology at University of Arizona and clinical investigation at Harvard. He then did 1 year of, he also went to medical school at University of Illinois, and he did 1 year of surgery internship at Northwestern and orthopedic residency at UC Davis. Then he switched to psychiatry residency at Johns Hopkins Hospital, and that's where I met Ajay. He and I were residents in the same class together, and he was already an excellent resident with an unusual background, and he was already marked for success in his career. After the residency, he went on to do pain fellowship in anesthesiology at Harvard and eventually joined the anesthesiology faculty there in 2002 and rose up to the rank of associate professor until he was recruited to University of Pittsburgh in 2013 to become professor and vice chair for pain medicine in Department of Anesthesiology. He has been established the internationally renowned investigator who has published over 200 peer-reviewed articles on clinical aspects of acute and chronic pain. He currently holds 3 NIH grants as PI and 5 other grants as a PI or site PI. He's also former president of the American Academy of Pain Medicine and also served as a senior editor of Pain Medicine, the journal, and a member of a NIH study group through over the years as well. He also has been a wonderful mentor to countless trainees and junior faculty members in many departments, including psychiatry, anesthesiology, neurosurgery, family medicine, and etc. And overall, his presence in the field of pain medicine has been unique as a psychiatrist, and his work has been recognized many times over, including the Distinguished Service Award and Founders Award by the American Academy of Pain Medicine. You know, recently I was asked by Mark Taubman, Dean of our medical school, and actually today is his last day as David Linehan transitions into the new role as the dean. When he asked me to kind of work on the multi-departmental strategy for pain medicine and pain research collaboration, the first person I thought of was Ajay Wasan, based on his experience and expertise and his reputation. And of course, you know, when I asked him for help, you know, he came all the way from Pittsburgh, and now he's giving us a grand round. So it's such a great pleasure for me to introduce my good friend, Ajay Wasan.
Oh, thanks. Thanks, Ben, for that wonderful introduction. And it's a real pleasure to be here. Dr. Lee in the Department of Psychiatry has been such a wonderful host. We had a wonderful dinner yesterday and some spirited discussions about pain. And I've also never had a sign language interpreter before at one of my talks, and it's an incredible honor, you know, to have that. You know, I feel like the governor, you know, when they do these, every state has a governor give their talks, they have a sign language interpreter. And then maybe I can get her to blush by complimenting her and keeping the complimenter. But there's where we go. And I see the motto here, medicine of the highest order. That's going to be a pretty tall, high bar to meet. And I hope I can try to come close to that when we're talking about chronic pain. So let me go through some of these. And so, you know, we'll talk about sort of a disease management approach to chronic pain using multimodal treatments. And this here is the flagship building at the University of Pittsburgh. It's called the Cathedral of Learning. It's 44 stories tall. It's the second tallest academic building in the world. So that's kind of what it's known for. This is sort of the icon. And these are some of my disclosures. I am going to talk at the end a little bit about some medical marijuana data and what it means for pain management. And what we'll do is we'll, again, talk about some of the key concepts involved in understanding chronic pain as a chronic disease. How can you practice comprehensive pain medicine in an interventional environment, sort of a practical way to kind of bridge the gap between an interventional approach and a comprehensive multimodal approach. And this will be more from the perspective of civilian medicine, and what works in civilian medicine, because the VA approach is somewhat different. It's more of a pure population health-based approach with stepped care, which is quite effective. And as the VA has been able to document really wonderful outcomes using that approach. And so what I'm going to talk about is an approach that really melds some of the classic multidisciplinary care and multimodal approaches, which are high quality and financially sustainable. We'll talk a little bit about the impact of psychiatric factors on pain treatment outcomes, the use of MRI to describe pain processing in the brain, and some big data approaches that are really helpful to helping us kind of execute and maintain that level of quality of care. So a few fun facts about Pittsburgh. It's about a 5-hour drive from here. And there's 2.3 million people in the metro area. It's more bridges than any other city in the world. I didn't know that. I moved there about 10 years ago. It's a home to Heinz ketchup. That was invented there. First gas station in the country was in Pittsburgh. Mr. Rogers' Neighborhood. Some of you old timers like me in the audience might remember Mr. Rogers' Neighborhood. And it actually is based in Pittsburgh by Fred Rogers, who lived in Pittsburgh. And it was filmed in the studio there. So, and so this is kind of where I work at UPMC, University of Pittsburgh Medical Center. There is the medical center, and then there is the medical school. They are connected, but they are different entities. And so it is overall the largest academic healthcare system in the country, and over 20 hospitals. That's within kind of the inner ring of Pittsburgh. There's actually another 20 in an outside ring, which is really throughout central and northern Pennsylvania. And there's even a satellite hospital that's in New York, upstate New York. And there's more than 400 outpatient locations, and UPMC has its own health insurance plan. It insures 2.1 million members, and approximately 40% of our patients have UPMC health insurance. So that's important because it's not a completely integrated care delivery network like you would find at Kaiser, for instance, okay? But it's sort of a partially integrated network. So what that means is that every service also needs to be good citizens and good neighbors working with the health plan to take some population health approaches. So for instance, providing approaches in pain management that are also helpful to the primary care doctors. So that's important too for how we designed our model. So as many of you know, chronic pain is a huge rampant problem, poorly managed chronic pain. There's 50 million adults in the United States who have significant chronic pain are engaged in treatment. There's a total of about 160 million people total who have some chronic pain. 25 million have high impact chronic pain, which is severe and disabling. Most of that chronic pain is chronic low back pain, then followed by arthritis pain and neuropathic pain. And as you all know, there's lots of ties between poorly treated pain and the opioid epidemic. So pain is a number one reason. The complaints of pain are number one reason that patients go to doctors in this country. And you can define chronic pain. There's a couple definitions, but the most really widely accepted is pain for at least 3 months on a daily basis. And as you know, there are lots of different treatments that are effective, but nothing is 100% effective. So for most treatments that are efficacious, meaning that in clinical trials they separate from placebo, doesn't matter what it is, an injection, a medication, physical therapy, mental health care, it's generally only about 40% of people that really have a significant response. And that's true for like all of our approved medications, for chronic pain. It's a very expensive condition. It's the second most expensive condition to treat behind cardiac care. And as a result, it's important to take this chronic disease management approach like you would for diabetes or hypertension. And the neuroscience is very strong on that. It really supports the idea of chronic pain as a chronic disease. And this is really just a snapshot of just give you some sense of the whole breadth of what's involved. Often, and we'll talk a little more about sort of acute going to chronic pain. But you have all sorts of mechanisms that are involved in the musculoskeletal system, all sorts of mechanisms in the nervous system that are involved. Peripheral nerve, spinal cord, brain, and all that together is really part of this corpus of work that really illustrates why chronic pain should really be approached and managed as a chronic disease. And this gives you some sense that there's another kind of rephrasing of that same kind of diagram. And there's this continuum between acute and chronic pain. And oftentimes chronic pain does start with some acute pain. It could be actually an injury, or it could just be gradually progressive pain that becomes clinically significant, for instance. And there's lots of different processes within the nervous system may sort of put someone on the path from going from acute to chronic pain, and then that pain being sustained and perpetuated as a chronic problem. There's all sorts of inflammatory components that can be there. You can develop peripheral sensitization in your peripheral nerves. You can have central sensitization at the level of the spinal cord and brain, and that involves structural changes as well as functional changes. There's lots of mechanisms. Each of these mechanisms that is involved in the transition from acute to chronic pain is also really important in perpetuating and amplifying chronic pain. You have ongoing pathology that goes on in the muscles, tissues, in the ligaments, in the joints, and the tendons. All of those can also contribute significantly to chronic pain and worsen it. And of course, we have all sorts of brain components. We'll talk about nociplastic pain, and of course, as often is a very strong mental health component to chronic pain that amplifies and perpetuates pain. It's very common and understandable, why people who have chronic pain develop psychiatric problems. Some of them had psychiatric problems before, but the vast majority actually developed their mental health problems after they had chronic pain. And then there's all sorts of impacts of just not moving around. If you just don't move around, joints that are not used rust. It's that's sort of the kind of the phrase we tell our patients. And just not being active itself is actually quite painful, and that's perpetuated by something called kinesiophobia or fear of movement, and that's important too. So a couple of important concepts, and when you're thinking about pain, we think about first nociceptive pain. That's the type of what we think about that we learn about pain in medical school. It's from pain transmission goes from peripheral nerves to spinal cord to brain through intact nervous system pathways. You think about fracture pain, routine postoperative pain. That's classic nociceptive pain. Neuropathic pain. So that's pain that is a consequence of a disease or a lesion to the nervous system. So the classic example is diabetic peripheral neuropathy, where there's damage to the peripheral nerves in the feet. That also can lead to sensitization in the spinal cord. And then a newer term for lots of the research that's gone on the past 30 years in this field is nociplastic pain, which refers to just dysfunctional pain processing, really to any level. So there's no damage, for instance, to peripheral nerve, spinal cord, or brain, but they don't process the signals properly. So think about fibromyalgia as sort of the example, which is a disorder of widespread pain. It's clearly mostly a brain disorder in which there's dysfunctional pain processing. Many areas of the brain are facilitating, amplifying pain signals, and there's also failure of descending pain inhibition. So I know Dr. Agea gave his grand rounds last week, and I'm just assuming he talked about all these things because he's way smarter on these issues than I am. And so that allows me to just kind of gloss it over and just say, if you have questions about it, talk to Dr. Agea. He's here, not me. He can probably explain it to you a lot better than I can. So the other aspect of nociplastic pain is that it's not just an issue of widespread pain. So you often have patients with knee arthritis who will say, yeah, the pain started in the joint. It was just there. It's kind of a grinding feeling of my bones. But then over time, the skin around the joint got more sensitive. My muscles started spasming, and I had this light touch, it's like burning, and now it goes halfway up my thigh. That's also, nociplastic pain kind of in action. So, and also, as all of you know, the epidemics of pain and opioid addiction are really connected. You have people on one side here who just have pain only and don't have an opioid use disorder component. So of this 100 million people with chronic pain in the country, approximately 10 to 15 million are prescribed opioids. These rates have gone down dramatically, but still the data shows that of those on opioids chronically, 5 to 10% will develop an opioid use disorder. Then you have people who don't have any, we don't know, actually it's not well characterized, but pain isn't their predominant kind of presentation. It's more of an opioid use disorder presentation. And they report very consistently in the addiction literature that 80% of heroin users started with prescription opioids, and 50% of those in opioid addiction treatment now actively have chronic pain. And of course, there's a common neurobiology between pain and addiction involving reward circuits in the brain and affective circuits. And both are also chronic diseases that need to be managed. Another kind of important concept here, and I know I'm going through things kind of quickly because I want to get to some data and describe kind of what we do at UPMC, is this idea of episodic care versus managing chronic pain as a chronic disease. And you all see this played out in every medical center, because lots of different specialties treat pain, right? You have pain specialists. They're actually kind of a small piece of the whole issue because there aren't that many pain specialists, no matter where you are. There's only about 7,500 in the country as a whole. But you have orthopedic surgery, you have neurosurgery, you have neurology, you have rheumatology, primary care, physiatry. All of those are really very much involved in psychiatry as well in treating chronic pain. So in episodic care, the role of the pain specialist is more to address spikes in pain, flares in pain right now, rather than addressing pain as a chronic disease. The amount of relief provided by the treatments is less important. It's more to get them past this flare, and treatments to get them past this spike of pain. The slang that's used is interrupt the cycle of pain. And establishing a diagnosis or appreciating all the multiple different inputs that amplify and perpetuate pain are less important. It tends to lend itself to more of a single treatment approach, such as only an injection. While a disease management model re-emphasizes the need for comprehensive evaluation and understanding of all the factors that may amplify and perpetuate pain, and then trying to put a long-term sustainable plan to address those factors in order to provide the maximum kind of pain relief that's possible. So naturally emphasizes the use of multimodal approaches, such as medications, physical therapy, injections of indicated self-management techniques, mental health care. It is more time-consuming, but it is cost-effective. And one of the other important things is there are some new changes in billing codes available that provide more revenue and RVUs for multimodal pain management. These are brand new. They only came out a year ago, and that really has tipped the scales in a lot of ways in favor of embedding multimodal care in any type of pain treatment setting. So again, episodic care would lend itself more to procedures, and if those don't work, prescribing opioids, which is a very consistent pattern you see in this country. You also may have episodic care be care that's provided only as ordered by somebody else. So an example is a neurosurgeon orders a diagnostic root block, and then that's all that pain specialist would do, and then that would be it. Disease management, of course, is ongoing care for the chronic condition. It emphasizes doctor-patient relationship and shared decision-making approaches. And this whole approach of treating chronic pain as a chronic disease has really been endorsed and advocated for many years through many, many organizations. The National Academy of Medicine has had prominent reports on this. The American Academy of Pain Management is very important on this. National Institutes of Health through the National Pain Strategy has called for this. So again and again and again, it comes up for this need. And it's not as if every patient who has chronic pain necessarily needs all these modalities, but you don't know unless you look. So the analogy I say is you got to look under that rock. You don't know what's under the rock unless you look under the rock. But if you look under the rock, you better be prepared for what you find, and be prepared and be able to do something about it. And that's kind of the agony and the ecstasy of treating pain, okay? Which is, it's an untapped mystery in every patient that you potentially can do a lot of things, but there's also potential you may not be able to make that much of a difference. However, on balance, there's a real significant, meaningful percentage of patients where you take a multimodal approach, you can really do a good job, and you can address a huge range of painful conditions kind of with this approach, whether it's headache, arthritis, neuropathic pain, back pain, et cetera. And so what you do in a multimodal approach is you think about this whole continuum of different types of treatments. Medications, obviously non-opioids are preferred. Is there a role for any injection that might help? Rehabilitation, like physical therapy, occupational therapy, and specific types of rehabilitation, because not all PT is the same. We encourage all our providers and trainees to prescribe physical therapy like they prescribe a medication. Is it fear avoidance physical therapy? Is it aerobic conditioning? Is it gait and balance training? Is it core stabilization? All that kind of things. So, and we have that as part of our multimodal plan. So every patient, every visit at UPMC in our pain clinics has to have in their assessment plan some discussion of whether each of these modalities is needed or not. And we've audited ourselves and we've published on our quality improvement showing that we're meeting that standard in the vast majority of patients that we see. And just to recap, one of the big drivers of this more personalized approach is that there's this huge variability in pain treatment response. In general, about 1/3 of the people will respond to treatments. Doesn't matter if it's PT or mental health care or injections, but 2/3 will either be the same or be slightly worse over time. And so that's a big impetus for this more personalized approach. And that's really advocated by Department of Health Use and Human Services. This is a really influential task force report on best management practices for chronic pain. Came out in 2019. It was really, in addition to HHS, it was really spearheaded by officers at the American Academy of Pain Medicine. I was on the executive committee at the time, and then I became president. And we really made sure this was a top priority. And really, many of the officers in APM were actually the key authors of this report, which I think is one of the best sort of laying out this same kind of issues I'm laying out. I think it's one of the best reports out there. And this is the key figure from that report that kind of summarizes kind of what I've been saying, is that you can imagine, say, 4 different patients with with back pain. And through a comprehensive evaluation, using all these different tools in the toolbox, that an individualized treatment plan can be created, which may be different. So the font's a little small here, but the graphic looks pretty good. You can imagine combination here. It's a NSAIDs, yoga, nerve blocks. Another person, short-term opioids, mental health, physical therapy. And different combination things that the patient thinks they want to do, that the provider thinks will also help them, and that's a whole shared decision-making process. And the step care approach of the VA, as I mentioned, is different, and it's different for a good reason. That is a different healthcare system with different needs, and they really need to have more of a population-based care approach with limited resources. So why do we do this? So the reason that multimodal approach is so that we're not doing this. We're not always chasing after the patient with a needle. Okay, there are times when injections and well-selected patients can be useful. But the idea is you have more than one tool in the toolbox, right? The old saying, if you only have a hammer, everything looks like a nail, right? That's exactly, one reason to do a multimodal approach. And it starts with a comprehensive assessment, a detailed patient history and exam. It needs to include a psychosocial assessment, a functional assessment, and there really needs to be, a long-term relationship and follow-up to see the patient in order to execute the multimodal plan, to figure out what's working and not working and make adjustments. It's not a static thing. So how do we do this at UPMC? So we don't have all the answers, but we think we have an approach that is helpful, that advances the care of these patients. And actually, after meeting with several people here at the medical center, I think all of you actually have the ingredients here to do this too, depending on the political will, of what's involved. So we have 15 different pain clinics at UPMC, including a pediatric pain clinic. 10 of these are hospital-based clinics, and 5 are primary care clinics, where we have a nurse practitioner we train embedded in that primary care clinic to act as an embedded pain specialist in primary care. We have a central location called Center Commons, which is about the center of the city, which is sort of a hub for a lot of our multidisciplinary treatment, where we have a really chronic pain dedicated and trained physical therapists, occupational therapists. We have psychology, psychiatry, addiction medicine, social work as well. But then each of our sites has some degree of these same services on site or nearby where they can refer to. And telemedicine has been a big help because we've been able to actually do telemedicine, pain psychology, telemedicine, psychiatry, just like everywhere in the country, but also telemedicine, PT, and OT, which has also been helpful. And so through this system, we're able to deliver kind of a total pain care where there's a pain specialist who does this comprehensive assessment and comes up with a multimodal plan and is able to get not every patient, but a lot of our patients to these other resources as needed, including health behaviors and addressing problematic things such as smoking or obesity, and then executing on this plan. And that's kind of the gist of what we try to do in an interventional setting. So the idea is that if you're trained classically as an anesthesiologist who did a pain fellowship, and you feel an injection is appropriate, sure, do that, but also do something else, and on top of that. And that's what's gonna help your patients the best. It's also gonna be financially sustainable. And it's really important, in this climate where things are changing on insurance companies. There's lots of issues with prior authorization, denials for lots of pain treatments. It's not just procedures, it's medications, it's all kinds of things. And it's kind of sad because once insurance companies realized that they can stop covering prescription opioids, and no one's going to push back on that, except for some patients with chronic pain who appropriately do well on opioids, that community. They realize they can start cutting everything else. And so that's what we're seeing massively in the past 3 or 4 years, is coverage for chronic pain treatments has really dropped. And that also makes it important to have more than one tool in your toolbox, just in order to take good care, of your patients. So this is a nice study from Steve Cohen at Hopkins. It was published 10 years ago that really illustrates this concept of importance of multimodal care. He took patients who had cervical radicular pain with MRI findings consistent with that, concordant with that kind of presentation. And they were randomized 169 to epidural steroid injections or what's called conservative care, which is meds. It could either be gabapentin or nortriptyline, and PT, that's a conservative care. Versus the combination. So the injections plus the meds plus the PT. They're followed for 6 months. The change in arm pain was the primary outcome. And they had these 3 groups, right? So you had conservative care, which is a meds plus PT, steroids only, or all that stuff together. Okay, so if you take a look at the 3-month outcomes, what you see is all three arms did well. So you had about 27% response in terms of responders, and responders was defined as significant change in arm pain, plus global positive impression of change. You have 37% who at 3 months having significant improvement in epidurals, and then you have 57% who had the combination, right? So clearly the combination outperformed, and that's at every time point, the combination kind of outperforms. And the combination is durable. So at 6 months, you still have 44%, who in the combination group who are better, versus much lower percentages in the conservative and epidural steroid injection. So I think it's just a nice illustration of the multimodal concept. And so now we'll talk a little bit about the brain. And as you all know in psychiatry, the brain is the main arbiter of pain experience, right? Whatever's coming up from the spinal cord, it's the brain that interprets those signals, turns them into pain perception, turns them into the pain experience, and the brain has the ability to modulate pain. It can act like an accelerator, and that's called facilitation. It can act like a brake, which is descending modulation. And you can have problems with your accelerator, problems with your brake, problems with the interaction between the accelerator and the brake. So those can happen. So obviously what people believe about their pain is important. Do they think that their pain's all gonna go away? Do they think their pain is gonna kill them, and if they move, they're gonna get paralyzed? And that relates to lots of thoughts about catastrophizing, that you all heard about. There's obviously lots of different structural and chemical, abnormalities in the brain and functional abnormalities that can lead to more chronic pain and perpetuate chronic pain. There's clearly a role of negative affective disorders and general anxiety and major depression that also have a significant kind of role. And this is a summary slide of some of that. At least 20% of patients in primary care who have chronic pain also have major depression or generalized anxiety disorder. It's much higher in specialty settings. In the pain clinic setting, it's something like 50 to 75%. Will have those huge rates of psychiatric comorbidity. And there's a broad range of mental health disturbances that patients with chronic pain have. And I like to break them down into what I call core psychopathology. Those are more the DSM-based categories, such as generalized anxiety disorder, major depression, or character pathology. And of the character traits, it's really been shown that neuroticism, from the Big Five personality model, has really been the most personality trait that's been the most predictive of a poor pain treatment outcome in the literature. And then you have more of the pain-related psychological symptoms, so pain-specific psychological symptoms, so catastrophizing over pain, anxious over pain, poor pain self-efficacy, pain-related anger. But if the majority of these people have an overlap, so if you have significant major depression symptoms, you're also very likely to have high pain catastrophizing. So they overlap. Actually, this overlap area, which you can call negative affect, this cluster of negative thoughts, emotions, and behaviors, is actually much greater than the individual sides of this equation here. And the correlations between these are between 0.6 and 0.7 in hundreds of studies, over 50 years kind of work. And of course, the greater levels of psychiatric comorbidity are much more predictive of higher pain, of more pain sensitivity and quantitative sensory testing, predictive of much more inflammation, poor disability, poor treatment response to all kinds of different treatments for pain, injections and PT and meds. And then, of course, you also have the prominent rate of substance use disorders, which is elevated in patients with chronic pain compared to healthy populations. That's a whole other area of psychopathology, that we won't necessarily go into, but that's another way that psychiatric comorbidity overlaps with chronic pain. So I'll talk a couple studies about this and to show you, illustrate a few things. So this one is one we published several years ago. We took patients with chronic low back pain and split them into groups of high and low psychiatric comorbidity. There was a moderate group, which we didn't track. They were actually excluded because we wanted to clear two groups. The high group had high depression and anxiety symptoms, and the low group had low depression and anxiety symptoms. And so they're phenotypically very similar, except for this issue of their negative affect. And they were prescribed opioids prospectively over 5 months, and the prescriber was blinded to group, and we tracked their average pain levels over those 5 months. Every week, we provide a summary score, and the low group is here. They had a 38% average change in pain, improvement in pain, over that time frame of 5 months, and the high group had a 19% improvement in pain. So they improved, but it really wasn't really that clinically meaningful. So typically in pain treatment, you're looking for at least a 30% improvement in pain to be really clinically meaningful, where you also see improvements in pain interference, and improvements in function. And some of the secondary outcomes, you look at their impression of change. The low group reported being very much improved. well, minimally improved in the high negative affect group, which is consistent with their lower level of pain improvement. Also, much greater opioid misuse. We had a structured way of tracking opioid misuse, and we've done a lot of work in that area as well. And you can see a 39% rate of opioid misuse versus only 8% in the low negative affect group. And we've done further studies that kind of look at this relationship between how does negative affect drive opioid misuse. You know, it's clearly that the patients with chronic pain and high negative affect are that's one of the most important risk factors for misusing prescription opioids. And so we were able to find that it's mediated, one of the mediators, opioid craving, that the patients with chronic pain and high negative affect report more craving for prescription opioids in between doses. They also report much more tendency and drive to self-medicate their anxiety and depression feelings with opioids. And we're following, this work up with a large trial we're doing now. This is funded through the NIH HEAL initiative. This is called Backpack because there was several $1 million carved out for back pain studies as part of the HEAL initiative. And what we do is we are taking 300 patients in 3 different sites across the country who have chronic low back pain and high negative affect. They may or may not be prescribed opioids. We randomize them to antidepressant treatment, and we have a validated algorithm we use. Or they get randomized to fear avoidance rehabilitation, or the combination of antidepressants plus fear avoidance rehabilitation. Now, it might seem obvious, okay, that of course the combo group will probably do better, but there's really not much data on that. So this is akin to the studies from 30 years ago on meds versus CBT versus the combination for major depression, right? It's almost exactly kind of what the pattern is and what the playbook is. So, and what we do in here is to the single treatments, antidepressants or the rehab, if they're not responders, they do have the ability to get re-randomized to the other treatment at 4 months. And then we're tracking, the improvements in pain and function combined as a metric, as well as changes in depression. And then secondarily for those on opioids, whether their opioid dose was able to be reduced, whether misuse went down, and that sort of thing. And this is actually the prelim data which we published in the same protocol paper. This was 71 patients with chronic low back pain and high negative affect. They were, some of them received and randomized to an education arm only for pain education. Then you have the antidepressant arm, the fear avoidance physical therapy, then the combination. And we're looking at every domain, the combination outperformed each individual treatment. So if you just look at who had significant improvements in pain, function, combined responders, pain plus function, or depression, it really, as you'd imagine, the combo did better. And that's what we're following up on in this bigger study. We'll talk about some other aspects of the brain's processing of pain. This is a study we published many years ago looking at arterial spin labeling, which is at that time, this was the very first study to apply that technique to the understanding of chronic pain and how it's processed in the brain. There were a lot of studies with giving people acute heat pain, on their arm transiently and seeing what lights up in the brain. And arterial spin labeling has several other advantages that I'll show you on the next slide. So what we did is we took 17 chronic low back pain patients who had radicular pain, had pain shooting down their legs. We did an ASL scan at rest, and then there's actually 2 visits. So during one of the visits, they would get the baseline scan. Then we would do these maneuvers to worsen their pain. They would do straight leg raising. We could measure how much we raised their legs, or they did sit-ups, or they did toe touches, things we could actually measure and reproduce that would create some lingering pain. On average, a 30 to 40% increase in pain that would sustain. And then we scan them again. So we get people in a low pain state and a high pain state. We had them come back and we did the same thing with heat pain. So we gave them transient heat pain that was matched to their clinical exacerbation of pain, which is just on the forearm is transient. So it's maybe 5 to 10 seconds. And then that went away. And then, so they don't have any lingering pain. They may, but it's highly unlikely. And then they get another ASL scan. And you compare baseline versus, the second scan. And so what you see is for chronic pain, this is the red for the clinical maneuvers and the back pain patients. You see a lot of the areas have increased cerebral blood flow, and there are advantages for measuring cerebral blood flow versus a traditional bold signal. Cerebral blood flow is a little more of a direct measure of neuronal activity. The bold signal does correlate to neuronal activity, but it's generally pretty well accepted that measuring cerebral blood flow is a little better indicator. And so you see this red bar are the increases in cerebral blood flow pre versus post in the low versus high pain, chronic low back pain condition. So all the classic areas you'd expect, there's that term, the pain matrix. Now it's called the salience matrix. And the pain matrix was one of the greatest scientific inventions as a term. It was like from some really smart postdoc 30 years ago, invented that term and started using it at meetings when the movie The Matrix came out. And then it caught on like fire. And then, but it's not really specific for pain. but that's how the term pain matrix kind of came about. So, since, for instance, the right somatosensory cortices, right anterior insula, and prefrontal cortex, classic areas that you see exacerbated heat pain, transient pain, also exacerbated in chronic pain, and you see very little activity and change in blood flow. So we have healthy controls as well that were matched to the back pain patients. They didn't really have any appreciable increase in their cerebral blood flow, as you would imagine, right? Because they don't have any chronic pain. Okay, so I'll wrap up talking a little bit about some medical informatics, and then we'll have good time for questions and answers. So one of the ways we achieve, this multimodal plan and achieve a comprehensive assessment in every patient at every visit is through a detailed kind of patient-reported outcomes battery that we administer in the waiting room. It takes, for a new patient, it takes on average 18 minutes to complete, and for follow-up surveys, which are shorter, it's 9 minutes to complete, and I can say that because they do it on an iPad, and we have a timestamp, so we actually know exactly how long it takes. We use the Choir software from Stanford, and then we modify it to suit our needs. And what we do is, we get a pain body map. We get all kinds of scales of pain and function and mood and sleep and mental health and neuropathic pain and impression of change. And we're able to display these little dashboards for the patient and the provider to see in real time during their visit, for any changes in pain over time. This just shows you what we're able to do with it. We're able to take the snapshot, copy and paste, and put it in the note. So it's there in the note, and we can actually use this for billing, and we're able to bill for it as well. And we started this in 2016. We have over 150,000 surveys and more than 50,000 unique patients. We were able to combine that with EMR data, and this was no small feat. This is a major challenge, but we were able to do it. And so that every visit, we have all the patient-reported outcomes, and then we have another approximately 100 variables from the electronic medical record, like diagnosis, orders, comorbidities, and things like that, and combine them. So every visit has all this huge variables which we can meld together, and that allows us to understand the treatment outcomes. And then we can also do comparative effectiveness and compare one treatment effectiveness versus another. And I'll show you a little data on that later, and using propensity scoring, techniques. So, and this is actually where a big part of my career shifted to in terms of research is the medical informatics. As you can tell, you can see the older stuff on the opioids and the negative affect, then the mid-range stuff on the fMRI, and now the next era of medical informatics I'm going into. And I just get interested in a lot of stuff, and that's one of my strengths and weaknesses at the same time, which is I don't totally stick with one thing all the time. And a little quip I like to say is our greatest strength is also our greatest weakness. So, take that for what you will. So this is a little snapshot of the things we can do, just to give you a snapshot. Phenotyping. This is 3,300 initial evaluations. We can look at average age and gender and race. Here's something important here. The mean duration of pain is 5.2 years, but the median is 2.1 years. So that means that 50% of all patients we see in a pain clinic are pretty early on in their chronic pain course. And that's a big stereotype that a lot of referring doctors have. Oh, they're just a chronic pain patient. They're never getting any better. They've had pain for years. Well, that's not really the case. When you deliver high quality care that's good for everybody, you are going to attract people that are fairly early on who have a new hot disc, who are still, 6 or 7 weeks out from the event where they have a lot of pain going down their leg or going down their arm. And, we can do something about it. And of course, majority is spinal pain, right? As you'd expect. So we can look at patterns of treatment. So this is a curated data set. It's 1,400 people. And this is from 3 or 4 years ago. We have a lot more data now. And I can tell you the snapshots we look at now look at just exactly like this over time, which is good. It shows we're delivering the same high quality care. This is a group that has both 3 and 6 month follow-up data. So within these 1,400 people, 69% were prescribed medication. The vast majority was non-opioids. And then you have 1/3 who got strong opioids, 1/5 weak opioids. Those are things like tramadol. 45% had some type of injection, 19% referred to our pain psychologist, 32% referred to PT/OT, and our outcomes were the same in 3 and 6 months. So this gives you a sense of, we're sticking to the multimodal kind of mantra. And we look at who reached benchmarks. So again, this is minimal clinically important difference benchmarks, which are standardized benchmarks in the field for changes in pain, changes in function, pain or function, also impression of change. Do they rate themselves as much improved or slightly improved? Either one of those was considered meeting that bar for minimal clinically important difference. So you can see that really meeting that bar, 50% for pain or function change at 3 months with the multimodal plan. And you also see, comparable improvements in pain, depression, and sleep, depression, and anxiety. So that's some example of kind of the outcomes data we can do and benchmarking. And we've been able to kind of maintain that over the years, and we've looked at that. We've also been able to do outcome studies with different treatments specifically. This is an example of medical marijuana. So New York is a legal state for marijuana, and Pennsylvania has a medical certification. So it's not a prescription. It's basically like a recommendation letter saying it's okay for this patient to go to a dispensary and buy cannabis. And we've been able to track who responds. So this is 3-month data, finding that 39% of the patients were significantly improved. And it was in different domains. It wasn't just pain. Sometimes it was their impression of change. Sometimes it was their function. Sometimes it was their pain. Sometimes it was a combination of one of those different domains. We also certify people as part of a structured plan to slowly wean their opioids if they're prescribed opioids. This is a subset, 128 prescribed opioids. And they had about a 39% decrease over 6 months in their opioid use as part of kind of a supervised wean. And we're able to apply causal inference methods and do comparative effectiveness. This is an example of that, the same marijuana data. We took those 440 patients and they were using propensity score. Well, this actually wasn't propensity score technique. This is a slightly different technique called stratified modeling. And we applied it to a group that was selected who received sort of conventional medication treatment. So it could be non-opioid or opioid treatment for their pain. It's different patients in the same time frame. So we got 2 cohorts that were treated differently in the same time frame. And with stratified modeling, you can actually get some degree of a causal estimate of the effects of one treatment versus another. And the odds ratio was 2.6 in favor of medical marijuana. So that means is that the odds of being a responder to medical marijuana are 2.6 times higher in that group compared to the control group. And the confidence interval was higher than 1. So that's important. You don't want in these studies, your confidence interval to go less than 1. And the second interpretation is medical marijuana has evidence of being comparatively more effective than conventional medication treatment in this population. And we're working on publishing that now. We're getting the draft together of that paper. So again, that gives you kind of a glimpse of all the things that we do and how we do them and how we really try to put research into action in our clinic. And I think that's also a key feature is for a high-performing pain service is to have research embedded in that pain service. And that's also an attractive feature to patients. They want to know they can go to a place where they can get the latest and greatest treatments that are being tested. So there's a Chinese saying, every crisis is an opportunity. And because the characters in Chinese for crisis and opportunity are the same. Interesting. I don't speak Chinese. So I read that somewhere. It's a nice quote. So, but pain medicine is this emerging specialty. Really, it's the same point in terms of we can think about emergency medicine, where that was at 40 or 50 years ago. Poorly treated pain is still a significant public health crisis, and there are a lot of trends now because of all of this epidemiology, all of this kind of failures of unimodal treatment and the changing reimbursement that really even greater emphasis and greater need and greater momentum and inertia is there to treat chronic pain as a chronic disease. And innovative IT solutions are helpful for us to deliver this treatment model with comprehensive assessment and multimodal treatment and monitoring our progress through quality improvement. And we think, it's scalable, that you can actually, in many different pain treatment environments, adopt this approach and treat huge swaths of patients, who are early on in their chronic pain course, who are maybe more treatment resistant and had it for many years, using just one treatment if that's needed, but more treatments if that's also needed. So again, you got to look under the rock and see what's there. So I want to, I have a lot of colleagues across the country that have really helped me and have been really important to a lot of the data I presented at the University of Pittsburgh, at Brigham and Women's Hospital, at Mass General, and the Imaging Center at Martino Center, where a lot of the fMRI stuff was collected when I was there. And this was a message, a graffiti I saw on a sidewalk a couple years ago in Pittsburgh. This was before COVID, and I thought it was a nice anti-catastrophizing, cognitive reframing kind of graffiti. And then I was walking past there like a couple weeks ago, past that same spot, and this is after COVID. And this is what had done after COVID. Someone came and changed the glass half full to kind of a glass half empty type of message. So that's how public sentiment can change, huh? So thank you very much. Here's the QR code. I guess I'll leave that up there.
Thank you, Ajay. That was a wonderful talk and also very timely talk, because as we are thinking about all these issues related to management of pain in relation to, many departments collaborating together. And you also made a convincing sets of slides, presented convincing sets of slides in relation to evidence that actually backs the superiority of a multimodal approach. But many medical centers don't do it, and usually it's related to payment systems or those kind of things. And are we ready to do this more of a, I guess, value-based care kind of thing?
Yeah, I think so. I mean, our data, shows that with the multimodal approach, we're not actually having any drop in volume or reimbursement. We're actually getting more, because we're able to do the injections efficiently if needed and do everything else. And with some of the changes now where initials and follow-ups are getting reimbursed more, it actually makes doing, follow-ups reasonable, right? And that's important to the multimodal care. So I think economically, the tide is there. The sea has changed a bit, and I think, so that's there. And then the other piece is getting people to play in the sandbox together nicely, okay? And, everyone has to give up a little and realize if they play together nicely, they'll all win. And it's simple. It's as simple as that. It's as simple as boys playing together in a sandbox on the playground. I mean, usually you don't see these disagreements between women, but it's usually you see these. Well, I won't go there. But it literally often that's what it comes down to is different departments deciding how are they going to play together or not. And I think, in my view, is that there's a big upside to actually compromising and working together to make a really comprehensive chronic pain unit. And I think that's and you can still preserve what each of the individual specialties are doing and keep what's really good about what they're doing at the same time. I think it's doable. So I'm optimistic, and medical centers, academic medical centers struggle with this all over the country. It isn't as if we've got it all figured out and we're the greatest. We got our own issues also. I think one advantage we've been able to do is we've been able to actually get anesthesia and psychiatry to really be more on the same page. So I'm a psychiatrist who's a vice chair in the anesthesiology department and runs a pain service, and that's really rare. But both fields are neuroscience fields, and they seem to appreciate the neuroscience from each side.
And we do have several faculty on Zoom as well as in person from anesthesiology department. And questions from the audience, Paul? Yeah. Paul, can you speak to the microphone?
So don't ask me too hard a question, Paul.
No, I just have a question about, I was saying first, great talk, thank you. I learned a lot. And my question is about buprenorphine, patients switching to buprenorphine. If you have data like the one you showed for medical marijuana about function and affect and pain. Yeah, so that actually, you are such a smart guy. That is an R21 we're submitting next week because we did that exact thing. We pulled the data from buprenorphine that we use for pain, and that's what we proposed to analyze because that's an important issue because there's some good systematic reviews saying we should be using buprenorphine more for pain. Right. If we're going to do an opioid, that should be the first line, or tramadol, okay, instead of any other opioid. But it's really hard to get insurance coverage for that. It's hard to actually get providers in any specialty, primary care, or any specialty to do that. So that's exactly what we're trying to look at now. Yeah, we're trying to look at its effect on the brain, actually. Exactly. Yeah. We don't have a brain piece in there for the grant, but that we're trying to just do the clinical outcomes piece.
Great. Other question. Now, my quick question, there are also a lot of trainees who are also here.
Jen had a question.
Yeah.
Oh, go ahead.
Sorry. So thanks, Ajay. Actually, I've never seen you speak about all your work together. It was very impressive. So I have a question. So one of the things I'm really interested in is this idea of providing, I mentioned to you last night, providing subsidized alternative or complementary therapies as a way to increase the multimodal care we provide, and also as a way to attract new patients to our system, so we can kind of balance this issue of doing the best care we can with hopefully increasing our revenues, or at least paying for that subsidized care. Do you have evidence from your data that suggests that once you started doing this multimodal care, that you actually were able to get more patients and therefore increase your revenues, so that we could support like a business model for doing that at our institution that we could share? Yeah, so we, because the way things are set up as hospital-based clinics, we had trouble providing some of the integrated medicine care in our clinics. We can do some acupuncture, but not everywhere. So there is an integrated medicine center that's part of UPMC we're sending people to. So we don't have that data. We have the data on the referrals we make, right, for acupuncture, massage, things like that, or chiropractic care.
And I think that makes sense because, as you know, there's over $1 billion a year people are paying out of pocket for CAM treatments. And so you can charge certain patients cash, at market rates, and then use that positive margin to underwrite, a more affordable rate for other people. And that's also a good way to get people interested because there are a meaningful percentage of people that are really interested in CAM primarily. And that's actually one of the questions on our choir because we had got some funding from PCORI to ramp up and modify and bring up to speed the choir software. And that was one of the things we added was a willingness and openness to CAM because it is pretty high. I mean, it is just eyeballing the data. I mean, it's a good 20 to 40% of people are very open and want to use CAM treatments as part of their pain treatment.
Anthony was telling me last night that one of the biggest risk factors for chronic opioid use and opioid misuse was not having access to CAM therapies. And so I think that that's another important reason.
Right. And it's part of the tool thing, right? If you only got an injection and an opioid in a toolbox, then that's all you're going to end up prescribing.
Thanks.
Any other question? Yeah, middle. Yeah.
Thank you so much for giving such a comprehensive talk on this complex issue. I really, really appreciate it, and I learned a lot. My question is for dual diagnosis, people who have substance use disorder and pain. Any interventional modalities or research based on that? Like what would be the first line? Do you do, or is there any research study coming up?
Yeah, so a lot of HEAL funding is on that. There's a substantial number of big grants now that were funded 4 years ago to look at that exact thing. What are the best treatment strategies? And I think that research is really going on. I mean, in general, it's kind of the principles is one, understanding their addiction disorder is number one. That's part of the comprehensive eval. What is it? And then, of course, it's maximizing non-opioid options as much as possible. And it's actually very hard in that population to get them to buy into that. So a lot of people are not appropriately motivated for non-opioid care. And they think that if they don't get an opioid, and that's part of the disease of addiction, that they think if they don't get prescribed an opioid, they're getting mistreated. And that's a huge barrier. So there's a lot of stuff both sides. And I don't have any great solutions or data for you, but there's a lot of research on that. So just keep your eyes peeled because there'll be abstracts coming out this year where people analyzing their data in the 5th year of their grants because they started in 2019 and now they're finishing up. So it should be some good stuff coming out.
There is a question from the Q&A from the Zoom. Can you talk about maybe pediatric side of multimodal approach to pain management, maybe even from your experience at UPMC?
Yeah. So we have a pediatric pain clinic at the Children's Hospital of Pittsburgh, and pediatrics it's a little bit different in the sense that it's always been much more multidisciplinary, multimodal. Behavioral factors, mental health factors, play an even bigger role in pediatric chronic pain. The majority of people we see there are adolescents, and so that's still the well-accepted standard of care is to have a multidisciplinary approach in pediatrics to this, And of course, the reimbursement's a lot better in pediatrics, so it's actually more doable to have financially a multidisciplinary pediatric pain clinic.
That's great. Actually, I also wanted to ask you, there are a lot of trainees in this audience as well and on Zoom as well. And I was just curious, you're a psychiatrist who's really has focused on pain as your center of your career. And can you kind of give your perspective where pain fits in the field of psychiatry?
Yeah, thanks, because that's a good question. I think, and there's been editorials written about this. Mark Sullivan at University of Washington has written about this. He's a psychiatrist who also does pain. He's been a mentor to me in the field. And, pain is a board-certified area of psychiatry. It was actually became board-certified in 2000, even before psychosomatic medicine did. And Ben and I were lucky. We trained at Hopkins where the psychiatry did a lot of multidisciplinary pain care, inpatient and outpatient pain rehab. And in my background, I did a year of general surgery, then I just did a year of ortho. I didn't do a full ortho residency. Then I switched residencies to a combined family practice psychiatry residency. And then in the psychiatry piece, being at Hopkins and doing all this chronic pain, I realized that chronic pain was the combination of orthopedics and psychiatry. It literally covers 90%, of what you do, except maybe like an epidural and local anesthetics. That's like the only missing piece. So I think it's really doable and important for psychiatrists to be interested in pain. I think they need flexibility. You got to start early. You got to start early as an intern, identify the interest, and get some flexibility from your program director to do the necessary electives and background. And I'm happy to talk to any resident from anywhere in the country about this process if they want. every year I do this, I get dozens of calls and with people, and I try to, mentor them and shepherd them on what to do. And it's tough because you do have to get some procedure experience. You have to have some competence with your hands to be able to do the procedures. You don't have to, have the greatest hands in the world, but you just have to be decent, okay? It's just like in medical school, the very first thing on the OB rotation, the very first thing the resident said is don't drop the baby. If you don't drop the baby, you'll be fine. Just don't drop the baby. So, that's what I mean. You have to okay hands. It doesn't have to be fantastic, but you have to show some competency in that. And if you have that as a baseline, psychiatrists bring a lot to the table, and a lot of them prominent people historically in our field of pain medicine have been psychiatrists because of the broad neuroscience training that we have, because of our ability to see multiple levels at the same, we're trained to see multiple levels of a problem at the same time and trained to see how they interact at the same time, and trained to do focused care for a problem as well as more longitudinal care. So the background in psychiatry really lends itself, I think, to being a good pain specialist.
Maybe a couple more questions. There's a couple of questions coming out. Is there any data related to how multimodal approach reduces ED visits or hospital admissions?
Yes, so we're publishing that now. So we have data showing that of our initial evaluations, on average in a population, after they see us, like for an initial evaluation, in the next year, on average, our population has half of an ED visit less. So it's not, we're saving half an ED visit. Now, there's nothing else been published on that. We're actually analyzing that further. But it is there, and that's really important because you can show that, and you can go to health payers and say, look, comprehensive multimodal pain care is going to save you a lot of money. One ED visit is minimum $2,000. And if they do any testing, it's really super high.
And there is one, I guess, last question. It's a loaded question, by the way. So, it sounds like you developed a wonderful collaboration between anesthesiology and psychiatry, but what is the state of collaboration in your experience at UPMC in relation to other departments like neurology, neurosurgery, orthopedics, and et cetera?
Yeah, there's collegiality. Some of those other services like radiology and physiatry have their own pain specialists, and they focus on more of their things. There is some cross referrals between them. There's not as much integration as I think is possible, or as much as I would like. So like I said, we haven't solved the problem either. I think we provide some comprehensive multimodal care. And I think we sort of started on that path because, we also, on the rehab side, separate from a physiatry department, we have very close relationships with the physical therapists and occupational therapists who are part of UPMC. So that's sort of how that's one way of pulling in the physiatry into this, but it's not a physiatry physician.
So, it's a wonderful, wonderful presentation, and thanks for everything. And we'll conclude today's grand round, and we'll leave his, contact information for those who are interested. So, thank you.
All right, thank you, everyone.